So we're talking about adults with cerebral palsy who are between 34 and 41 years of age who are having visits for fall-related injuries, and adults with intellectual and developmental disabilities who are between 42 and 45 years of age visiting the emergency department for fall-related injuries at similar rates as those without intellectual and developmental disabilities who are age 65.
All right, I am here with Dr. Mike McKee and Dr. Teal Benevides. Thank you so much for joining us for our podcast.
It's great to be here. Thank you.
Thank you so much for having us. We're so excited.
Thank you. So, basic question that I asked all of our guests, how did the idea for this study come about?
That's a great question. So the lead author of the study, Dr. Natalia Cantet, who's a postdoctoral fellow at University of Michigan, led all of this and brought us together. And the study is a part of a larger grant, which I'd like to invite Dr. McKee to share more about. But essentially, we are interested in understanding disparities in access to services and supports for people with disabilities broadly. And our specific study is about people with intellectual and developmental disabilities. Dr. McKee, do you want to share a little bit about the broader grant?
We want to acknowledge where we got our funding. This was through the National Institutes of Disabilities, Independent Living and Rehabilitation Research. We call it NIDR for short. And the overarching grant title is actually Advancing Health Equity for Adults with Disabilities from Diverse Communities. And this was part of the RRTC. What we're really interested in is just looking at individuals with disabilities, especially through intersecting identities. These are individuals that we have identified as having compounded risk disparities, especially in the healthcare side.
In looking at reasons for emergency department visits, we identified that people with intellectual and developmental disabilities who have difficulty accessing services, preventive healthcare services, and so many other services were going to the emergency room for injuries. And in bringing this to the larger grant team, we asked why? Why are people with intellectual and developmental disability visiting the emergency department for injuries? And one of the project partners, Dr. Haley Miller at the University of Michigan, her work is on how sensory and motor systems develop across the lifespan for people with intellectual and developmental disabilities. And she brought to our attention that potentially falls are happening much earlier in people with intellectual and developmental disabilities. And so we specifically asked the question, are fall-related injuries occurring in people with intellectual and developmental disabilities? And are they visiting the emergency room for these types of fall-related injuries? And that's what led us to the current study.
Could you give us a brief synopsis of the study and its key findings?
Absolutely. So our data rely on very large data sources from the Healthcare Cost and Utilization Project. We call it HCUP, which is from the Agency for Healthcare Research and Quality. HCUP data can be purchased either at the national level or at the state level. And we purchased 21 states and their emergency department data after their review of our data use request. And so these data represent 100% of the emergency department visits in each of those states that did not result in an inpatient stay. So we're talking a very large data source from each of these 21 states. And what we did is we examined the likelihood that a particular visit was for a fall-related injury, which is a code that is used within the data source. And we identified the rates of fall-related injuries among people with IDD, adults with cerebral palsy, and people without intellectual or developmental disabilities or cerebral palsy. And we compared the proportion of fall-related injuries being seen in the emergency department at different time points from 18 all the way up to age 80. And the main point is that even though we think of falls as happening to older adults, age 65 years and older, is that key age that we think about, the proportion of fall related injuries in adults without disabilities at age 65 is about 7.3% of all of the emergency department visits. We were observing that same proportion in much, much younger adults with intellectual and developmental disabilities and adults with cerebral palsy. So we're talking about adults with cerebral palsy who are between 34 and 41 years of age who are having visits for fall related injuries, and adults with intellectual and developmental disabilities who are between 42 and 45 years of age visiting the emergency department for fall related injuries at similar rates as those without intellectual and developmental disabilities who are age 65. So to say it again, really succinctly, adults with intellectual and developmental disabilities and those with cerebral palsy are visiting the emergency room for fall related injuries at much, much younger ages than adults without intellectual and developmental disabilities. And we should be very, very concerned about why this is happening and how to prevent it.
I just want to follow up. In terms of the differences that we're seeing, and obviously in age groups, one of the key things is that falls is a very dangerous thing. It's one that often leads to a lot of mortality, morbidity. And for primary care, this is a really great study, has a lot of implications for us, partly because obviously we're thinking about how we can prevent consequence of a fall. Often there's going to be a lot of things around that. We do already incorporate a number of both screenings, notably it's for the older adults, and having it be mindful that there are certain patient groups that we should be thinking about at much younger ages. And we're now getting into this era where leveraging clinical decision support tools, diagnosis codes, not working harder, but thinking how we can identify these people quicker and be able to identify high-risk groups. So this is really going to be very helpful in lowering the ED visits, the hospital visits, and also reducing costs, which is obviously a big aim for primary care.
Thank you so much. IDD is a rather broad category. We were wondering if you found that certain subtypes were more represented than others among the patients in this study.
That's a great question. And I just want to make sure that your audience knows that the HCUP data represent visits. They don't represent unique patients. So some people might be represented in the data set more than once. So when we're talking about the data, we're talking about visits and not patients. But when we do look at the types of intellectual and developmental disabilities that are represented within the visit records, we do see a larger number of adults on the autism spectrum, quite a large group of people with intellectual disabilities with the ICD-10 codes ranging from the mild, moderate, all the way up to severe and profound. And we also have a smaller number of individuals who are identified with genetic types of intellectual and developmental disabilities.
In terms of IDD, it does have a lot of different diagnosis codes that are eligible on it, but we have also really leveraged a lot of the work that took place before. This is a multidisciplinary team, and there was previous work that helped to kind of refine which ICD-10 codes to include. So that was really helpful to kind of build up and have more confidence in terms of who we were going to include.
Excellent. Thank you. You bring up the point that this is a marginalized patient population, and there are implementation barriers. There's the obvious time in your standard PCP visit, there's just not enough time. Are there any other implementation barriers that you think are important to bring to light that are specific to this patient population?
So in a primary care setting, there's a number of barriers. Some of them could simply be stigmatizing kind of attitudes. A lot of primary care providers also basically say that they do not feel comfortable caring for this population. And so there's a lack of training, education for clinicians, which is part of the issue. And then we also have just barriers across, whether it's structural communication barriers, and that also further erodes the ability to get quality care, and also it diminishes the trust that they have in the healthcare system. And then the other part, this is a population that does often have a number of comorbidities. And so it can be a population that has higher risk across the board. And so that's why it's important to make sure that we have adequate attention to address many of those things which are preventable. But it does, you're right, it does take time. And I do believe that when we recognize where those potential risk factors, so ball being one, these are really critical junctures where we can think about how can we provide better support? Do we think about doing a home assessment? Do we think about medication review? Often many of them are on a pretty lengthy list of medications, which can increase the risk of falls. So again, what we're trying to do is really look for those big areas that can actually have a big impact on the quality of care and also reduce a lot of unnecessary ED visits, hospital visits, or even worse, mortality and morbidity as a result of the fall.
And I'll just add that people with IDD share that their providers very rarely want to know what their goals are and support their specific goals in the context of the care settings. And they really want to be able to communicate what is important to them. But time barriers, reimbursement barriers, accessibility barriers, and even getting to an appointment or from an appointment due to transportation needs, all of those things prevent people with IDD from having meaningful relationships with their care providers and getting the kinds of care that they need. And so, as Dr. McKee was sharing, there are a lot of access barriers, and we can do better. We would be remiss to not talk about communication as a huge barrier, and that many providers are not trained in how to communicate with people who might be using AAC devices or who might use pictures or other tools to communicate, sign language. All of those things are barriers in communicating with patients about their goals. And that would affect people with IDD even more so than probably the general population.
Are there any other types of disabilities that you think could benefit from this kind of study and what you found from this study?
Yeah, I think this is a study that is often going to spill over and potentially impact other population groups. One group I think that we need to also consider is people with physical disabilities. And some of the individuals that are part of this study most likely had other existing physical disabilities. So cerebral palsy, I know was focused. So cerebral palsy also has a number of physical limitations too. In terms of other groups for the physical disabilities, even sensory, there's potential things that we do need to identify and think about fall risk. So people with low vision, even people with hearing loss, like aging into hearing loss, are at elevated risk for falls. We still don't understand all the mechanisms for all of them, but we do know that there is a strong association there. So looking at physical, sensory, and also now with intellectual, these are all groups that we need to be mindful. And maybe it does include other groups for disabilities, something more inclusive. But obviously, further work would have to be done to identify that.
Thank you. So we're going to shift now into the hard data and hard science. To start off with, one of the things that you used to analyze your data was a G computation. Could you tell us a bit about what that is?
Sure. Let me just start by saying that our sample includes people who visited the emergency room. We're not talking about everyone with IDD. We're talking about only those people who visited the emergency room. And people with intellectual and developmental disabilities, there just might be an underlying reason why they go to the emergency department more or less than people without intellectual and developmental disabilities. And we don't know, there's some unmeasured reasons potentially that those two groups differ in terms of why they visit the emergency room. And those are unmeasured confounders. We have no previous data for these individual visit records. These are not claims data. We don't know anything about their previous utilization. And so we have to adjust for unmeasured confounding in terms of why people might be even going to the emergency room to start with. And because of those unmeasured confounders, there's no variables in our data that we can use to adjust the regressions. We use the G computation approach, which will take that unmeasured confounding and say, let's assume that everyone had this particular group of reasons for visiting the emergency room, or let's assume this other group had a similar number of reasons, and it adjusts the observations for that type of unmeasured confounding, assuming everyone is in one group or another group. And so we ran all of those comparisons. And what you'll see in our table where we compare people with intellectual and developmental disability to people without intellectual and developmental disability at a specific age is the assumption of if we assumed people were in one group versus the other. And the G computation helps us control for that unmeasured confounding.
Could you tell us what the Elixhauser Comorbidity Index is?
That's a great question. So the Elixhauser Comorbidity Index is one tool that researchers have to control for co-occurring conditions. I just mentioned that there might be reasons why people would go to the emergency department more or less than others. And I think your listeners are going to know that people who have a large number of co-occurring conditions, we're talking heart disease, diabetes, previous stroke, high cholesterol, all of those things compounded could create more of a likelihood that somebody's going to go to the emergency department or go and be admitted to the hospital or even have higher risk of death. And so the Elixhauser Comorbidity Index was a tool that was developed several decades ago that basically counts the number of co-occurring conditions that somebody might have that contribute to greater lengths of stay or greater reasons why they might be in the hospital longer than other people. In our data set, because we only have a single visit record, the Elixhauser is somewhat limited because we can't count all of the things that might be occurring over a longer period of time. So we are able to look at within that visit record the co-occurring conditions that a particular ED physician reported, but it may not be the most comprehensive. That said, it was all we had, and this was our best attempt to control for what kinds of co-occurring pre-existing conditions somebody might have had upon visiting the emergency department.
Again, there's this perception that this is a sicker population, a population that is not healthy. So that helps to offset and at least control for some of that as long as the data is there. But it also does highlight that despite adjusting for that, there was still a significant risk factor for falls. And so that's important to recognize as well.
That's a very important point. This was a cross-sectional observational study that used data from 2019, and something that we hear a lot, I'm sure that you've heard a lot in research is, well, this was before COVID. How have things changed since COVID? So I was wondering, and I'm sure our listeners would like to know, if there have been any indications on how things may have changed since COVID in 2020, just the following year after the year that you drew data from.
Yeah, thank you for the question. So the COVID-19 pandemic, unfortunately, had a really profound impact on the patients with IDD. They were at much higher risk for having complications and mortality due to that. But in terms of your question about has things changed in terms of the access to care, how we're managing things, and also whether they go to the ED visit, I don't see there's anything major. I know a lot of us have now incorporated virtual visits, so it does provide some level of care. Unfortunately, access to care for patients with IDD, it's so problematic, and we still have the lack of training. We still have stigmatizing attitudes. We still have not done a good job in terms of coordinating care. And so all of those things, unfortunately, have not improved. I don't know if they're necessarily any worse. So I think at this point, in order to see if there's changes over time, I think the key thing is really looking at the next set of data that does include those COVID-19 pandemic years. So it's kind of a TBD at this point.
Looking at one of your tables from the paper, table 1, that shows a risk difference in percentage points between each group. You have the IDD, CP, and then no IDD or CP. In general, it increased with age, but in the CP group, there was an increase until the age 34 to 37 group. It hit 4.06, then it dropped back down again. and then started increasing, hit a trend of 5.23 at age 46 to 49, and then dropped back down again. And that stood out to me when I was going through the data. Is there any reason that you were able to identify as to why there was that kind of gradual and then the drop down and then the gradual increase again and then the drop down?
That's a great question. And when we look at these data, we do try to keep in mind that these are basically a proportion of ED visits that were for fall related injuries. And so, one of the questions that we have is during those age years, were there other reasons why people with cerebral palsy visiting the emergency room for other reasons that proportionally taking away from essentially what we observed were fall related visits? That would be a different study, but that could be a potential explanation for the observed little wobble there in the risk differences. Specifically, that as people approached middle age around that 38 period, that there were other things that were causing people with cerebral palsy to visit the emergency department for. And so that does bring up other questions, right? Which is these visits are in proportion to other things. And so our team continues to look at these reasons for a visit. What are other reasons why people with intellectual and developmental disabilities are visiting the emergency room, and for what reasons at different ages? And so I can tell you we've started that process. And we've found some interesting things around the earlier age ranges. For example, those that are in the earlier age ranges are visiting the emergency department much more for mental health reasons than for things like falls or other physical health reasons. But I think that question still remains unanswered related to these specific data. Dr. McKee, do you have any other thoughts on that important question?
I think there's still a lot of uncertainty, and that is why we do need to get further observational studies and really get into the charts and clinical, claims. So I think those are really next steps for everybody.
To me, and I know I'm not alone in this, the marker of a strong study is when it births all these other questions that might turn into their own studies. So this is very exciting. To go back a little bit again, in an ideal world, there's a multidisciplinary team that takes care of all patients, but especially patients with different types of disabilities. Do you see any way, drawing on this data, that rehab experts can work with PCPs to get patients with disabilities what they really need?
I do see a strong need to work closely with our rehab experts. So physical medicine rehabilitation, physical therapy, occupational therapy, and so on. So obviously, this is a population at much higher risk for falls and much younger ages. So I think the first and foremost thing is to think about obviously maybe screening them at much younger ages rather than waiting until there's a problem. And so the second thing is coordination, especially in primary care. That's a critical part of what we do. And I think that could really be helpful for these patients. And not only just the exercise, the strengthening, they can think about gait stability. And so there's those components too. But the other thing that could be really valuable, especially with occupational therapy, is thinking about what additional devices do they need a walker? Are they at a point where they may need other devices to help support? They may need a home assessment to see if there's any fall hazards and try to get things in place. And also, really, just to be able to communicate with the family, their loved ones, and think about, if there's going to be potential hazards, can they renovate the home? Can they make changes? Or do they have to avoid certain situations that could be problematic? What we want to do is really try to enhance their ability to be involved in all components of life. But the key thing is really working with the team, leveraging other skill sets that we perhaps don't have as much training. So again, when we think about assistive devices, tools, that's where I think primary care, by working closely with the rehab experts, can get a lot of those additional items and insights.
I'll say, as an occupational therapist, I 100% agree. I think that rehab professionals, and especially occupational therapists, because we do have the ability to do that home evaluation, that assessment of the environment in which people are navigating. So, not only where somebody might be living, but also if they're traveling in the community, do a community assessment. What are the potential places where they might be falling when they're getting on and off the bus for public transit, for example, or when they're navigating in the grocery store? So, really working closely with the primary care providers, but also people with IDD in their home and communities to understand what goals they have for accomplishing their everyday life activities, and then assessing how we can support them in that in a safe and effective way, which might include physical strengthening and other approaches, but it also might include environmental assessment and modifications, as Dr. McKee noted. I think a couple of barriers to that, or ways that we can improve that collaboration. One is rehab professionals are not often in those primary care settings. And so we need medical homes in which people include providers with different backgrounds. We also need reimbursement mechanisms for those providers to be delivering services. I completed a study a couple of years ago looking at the use of occupational therapy among people on the autism spectrum. And it's often not something that adults use, which is very odd. So we do need to be thinking about reimbursement and ways in which those providers are being referred to and provided with the opportunity to deliver care.
Especially for my patients with IDD, there's a comprehensive medication review. We call it CMR for short. Again, medication, especially if there's a lengthy list of medications that they're taking, can really be problematic. And trying to eliminate things that are unnecessary, or maybe lowering the doses. So that's another component. And also really just communicating with the other specialists is important, because there may be miscommunication where they're treating a condition that's no longer there, and whether it's chronic pain or maybe they're having neuropathy. So those are things that beyond the rehab experts, and I think are really, really important to help.
Are there any other guidelines that, after seeing the outcome of the data with this study, that you would say should be changed, or what policies maybe need a second look to be changed?
I think it's really critically important to understand that we need data, we need more studies. That would be really helpful in implementing guidelines. So we often in primary care think about the United States Preventive Service Task Force. But one thing that is going to be difficult is that when we talk about subset of the patient population, it's hard to get clinical trials that only focus on a specific condition. And so that might be a tall ask in terms of getting to that spot. So internally at our clinic, I already incorporate a lot of these fall screenings for patients with IDD. And I would strongly encourage, I think there's enough data to really suggest doing that. I think there's very little harm of doing the screening. So I think it really just opens up a number of things where it leads to medication review, also help people get connected with other, whether it's therapy, to improve the quality of life, and also be able to, from a physical standpoint, be able to have more stability. So in terms of guidelines, a lot of it, unfortunately, is still expert-based, opinion-based. But I think the study obviously shows very significant findings to really encourage that.
I think quality measures often exclude people with intellectual and developmental disabilities from the denominator in terms of when payers are assessing how clinicians are providing best practice care to their patients. And we really need quality measures that include people with IDD and are specific to people with IDD and the kinds of care that they get. So a team that I'm a part of has been doing work with NCQA to identify which quality measures might be able to be modified to include people with intellectual and developmental disabilities. But we need to be improving the quality of care and then thinking about how we can incentivize and then support providers in delivering that care. Because right now there are some mechanisms that disincentivize the delivery of care through no fault of the clinicians. But when you have a lot of things on your plate that you need to assess, it can be difficult to ensure that they all get done in a 15-minute window. And so I do think it's important for clinicians to think about the screening part, but I also want to put a call out to our system leaders that we need better incentives to support better quality of care. So not just the guidelines that tell clinicians to do something, but then let's tie it to specific reimbursement mechanisms so that they are delivering care and being paid for the quality care that they deliver.
I agree with Dr. Benevides that in terms of the support, the wraparound, the billing, all of that is going to be really vital to be able to provide better care for these individuals. One thing just to highlight that in terms of all screenings that we already do, it exists. We have it for 65 and older, part of our Medicare wellness visit. The CDC also recommends it. There's already fairly good data that the United States Preventive Services Task Force does have encouragement to do a lot of the therapy around fall prevention. So we have an infrastructure that already exists, and this actually can be leveraged to expand to a longer, or what I would call a greater age span for this population based on the findings. I think we have the infrastructure that's already in place. I think this is probably an area where we can be able to pivot pretty easily.
Excellent. Is there anything in closing that you would like to speak to at this time?
When we identify somebody at fall risk, one important thing to think about is bone density. I know that was beyond the scope of this study, but bone density often can be lowered. Again, some of it is medication, some of it is based on their specific diagnosis, whether they may have a lower muscle mass. So that might also result in further exploration. So you might have a DEXA scan that might have to be done at a younger age. And what that can do is actually, while we're trying to prevent the falls, even if they do fall, if we're trying to make sure that they have adequate calcium supplementation, vitamin D supplementation, getting them stronger, but sometimes even we have to provide medication like a bisphosphonate. And so that is all something that I think part of this study in the future we might have to also include too.
I would just add that I think that primary care providers are essential to shifting practice for people with IDD. They really are the frontline group that is going to be able to deliver the best care and think holistically about that person. And so I'm just really thrilled that the Annals of Family Medicine sees this as an important topic because people with IDD are our patients and they grow into adults and live healthy, long lives if we can support them. So much work focuses on children, but very little is known about adults. And so I'm really proud of this study and that Annals of Family Medicine has found it worthy of publication. So thank you for that opportunity.
I agree. Really appreciate the other focus on this.
Thank you. Thank you. Thank you for doing this work. Thank you so much again for joining us. I know you both are very, very busy, and I'm so thrilled to speak to both of you and look forward to seeing the future and what comes after this.